I think that you have given us an update on the new drugs and certainly have outlined many issues that guideline groups need to look at. I think it's been very clear with carboplatin for quite some time that the magnitude of benefit by adding an NK1 is relatively similar to that of cisplatin. And once again, it's an underperceived need, and hopefully the guideline groups will react favorably. NCCN, as usual, did not wait for data, but called it correctly and has said that. Questions for Dr. Roila? While we're waiting for questions, may I take you to task, my friend? I think that the two studies that Dr. Roila presented to us are extremely important of his recent studies, where only one tablet of aprepitant is given on day 1 and nothing thereafter. One thing we've not done very well in oncology and in antiemetics is define the lowest fully effective dose. The 125, 80, and 80 typical dose of aprepitant is quite arbitrary. There's really no evidence that multiple days is better than a single day. In fact, the publication 15 years ago in the New England Journal of Medicine by Navari et al., which was a randomized phase 2, showed 5 days and 1 day to be very, very similar. So I think maybe you've muddied the water with this business about metoclopramide for delayed emesis. We have no knowledge whatsoever that you need metoclopramide when you give an NK1. I think that you have defined, you're getting closer to defining the fully effective dose, and that for the doses of cisplatin and for AC that you have shown, 125 pill should be just fine. There was no evidence that fosaprepitant needed to be given at 150 instead of 115, 115. And so companies don't necessarily want to do such a good job of defining these doses. So I think the guideline groups ought to look at your data, and I think in my clinic I already have done for AC and cisplatin following Dr. Roila 125 on day 1, and that's it. I wonder if many patients, if 80 milligrams wouldn't be sufficient for many patients as well, as such. Fausto's studies are large, they are unbiased, and they're well designed. Do you agree with me?
I agree completely, of course, but I would like to add something. If you look to the history of antiemetic development, consider that now we use 3 milligrams of granisetron in Europe and 1 milligram in USA. This because different dose-ranging double-blind studies evaluating the optimal dose of granisetron did not permit us, even if probably 1 milligram is the correct dose, to arrive to a final conclusion about the optimal dose. The same for ondansetron until recently, no? Because in USA the dose was 32 milligrams, in Europe was 8 milligrams. This despite we have large double-blind randomized studies evaluating the optimal dose. Therefore, the statement of Dick is strongly correct. We have not idea about the optimal dose of aprepitant on day 1.
But I think you've shown us that 125 is just fine, because you gave, in your cisplatin study, you gave the full 3 days, and it was no better than 125 on day 1. I'd be shocked if metoclopramide makes the difference, especially at those extremely low doses. Other questions for Dr. Roila? Dr. War.
This is looking forward to something slightly different, and that's the potential advent of nitupetant and palonosetron. one of the reassuring things with aprepitant was the lack of interaction with taxotere and vinorelbine. Although the product monograph said that there should still be caution with certain drugs. The product monograph for this combination actually mentions that for docetaxel, there's a 30% increase in the area under the curve and a 50% increase in the Cmax of docetaxel. And that's sort of equivalent to the difference between 75 per meter squared and 100, which we know from a couple of studies does make a difference in toxicity. Should that make us nervous in any way, or how will we deal with that? Because there certainly is a difference if you up the dose of docetaxel by 1/3. That would be important. Will we wait to see the study that's based on, or I was a little bit puzzled by that. I found it difficult to believe.
Let me enlarge a little bit on Dr. War's point. He's referring to the fact that both nitupetant and aprepitant are metabolized in the cytochrome P450 3A4 system, which is why the doses of dexamethasone are different. What we didn't talk about is that there is evidence that rolapitant, the drug that Dr. Roila mentioned, is not metabolized by that pathway, which is a rather interesting finding. 1/3 of all prescribed drugs are metabolized through 3A4. Taxanes, Vincas, and several other agents that we use are metabolized by 3A4. I think that we need to see the original study because this is quite different than what we saw before. And I think we need to see the whole profile. Package insert for the combination, the NEPA combination of nitupetant and palonosetron, is in most ways extremely generous by the FDA. They allowed them to have an indication for many aspects that are not necessarily well studied. And at the same time, as a risk-averse agency, they may be saying something about the other drugs. So I think we need to see the original studies on that. Fausto?
I agree, of course, but I would like to add only a sentence. Docetaxel, if used alone, didn't require any NK1 receptor antagonist. The same for vinorelbine, of course. But that said by Dick is very important because there are a lot of interactions that have not been studied, very well studied, and this is urgent to study, to do.
So we know that 3A4 affects oral drugs more than it does intravenous. And I think because of this reason, when people give dexamethasone intravenously, they are probably reducing the dexamethasone unnecessarily because it's the oral dose that the main effect is on. In Europe, there is the availability of oral vinorelbine, oral navalbine, and there is no effect with aprepitant on the metabolism of IV navalbine, as was shown in a PK study. But I'd love to see what happens with oral vinorelbine, because strangely, oral vinorelbine actually has more emesis than others, and of course it can be given with cisplatin, so therefore it would be there. So I think those studies should be required by the agencies that should be done with the oral drug. I think that may be where the real change occurs. There's a question? Yes, please.
Thank you very much. I think it's very interesting to ask about the optimal dose of aprepitant, but I think we should also ask the same question about the optimal dose of cisplatin in palliative chemotherapy in pathologies like lung cancer, where we know that there is no correlation between overall survival and dose intensity of the treatments.
Well, there is evidence that would disagree with you on that. And based on an analysis of 10,000 patients that shows that there is a dose intensity difference, that if you I know that's not the topic of our conversation, but if you give less than, if you look at it, make these equivalent to weekly doses, if you give less than, in lung cancer, 20 non-small cell, if you give less than 20 per meter squared per week, you have an inferior result than if you give between 25 and 28 that if, per week, based on this. If you give 30 or more, you have another inferior dose. Inferior, it's too high. Okay, so there is some evidence to disagree with that. In small cell lung cancer, I agree with you entirely. It's very difficult to see that anything over 60 per meter squared every 3 weeks is any different. But we could have a very enjoyable time talking about this, but I think it brings up the fact that we have not identified the lowest fully effective dose of many drugs. For instance, David brought up 100 per meter squared of docetaxel versus 75, but in Asia they often give 60. And I'm not sure that 60 per meter squared of docetaxel is any different than 75, but again, we haven't defined that very well. If we did define this, this would have many supportive care implications, which is, I think, what your point is. That if we know for different diseases that we can get the same effect for a somewhat lower dose, then we'll have fewer acute and fewer chronic toxicities. Dr. D'Acato.
I would like to make a comment on the previous discussion about the combination of drugs. When you talk about the Vinca, I don't know what is in the package insert that David Ward just mentioned, but you should not forget that when you give one drug to a patient, you can guess what happens. When you give two, you are just not so close to the reality. And when you give three, you have no idea what happens. So you just have to see. So we have not had any comments about PGP. And vincristine is highly dependent on PGP. And PGP is highly dependent or modified by many very common drugs like verapamil or some sleeping pills and so on. So if you look at toxicity and at under the curve also for the taxanes, you also should look at other drugs that the patients are taking. This is just a comment.
No, it's perfectly correct. And it is amazing to go into the chemotherapy unit and see the number of drugs that the patients are receiving, both supportive care, chemotherapeutic, and the drugs they were already on. It was a very interesting study that Florian presented to us today about stopping statins in patients with stage 4 disease. Other questions for Dr. Roilo? Other comments that people would like to make in antiemetics? I think that most of this is what we're talking about. It's interesting we haven't talked about patches or other forms of giving antiemetics. I think most of us don't really see any particular advantage to these fancy ways of giving old drugs. Thank you very much.